this talk on workhorse procedures for ptosis correction, and I'll take you through the 4 surgeries that we have in our repertoire for correction of ptosis. Levator resection, that most of us find pretty comfortable in our hands. The newest kid around the block, which is frontalis muscle flap, a little bit on Mueller's muscle conjunctival resection and posterior approach to ptosis, and then finally frontalis sling. So here's a girl who has right moderate ptosis. She has a levator action of about 6 millimeters, and you can see that I've marked the eyelid crease to match the contralateral eyelid crease. And I do that with cold steel, and then I dissect the orbicularis over the tarsal plate to expose the superior border of the tarsal plate. You can see that here. What I'm now doing is raising the undersurface of the levator, disinserting the levator from the tarsal plate and dissecting along its undersurface, and then on the superior surface of the levator. I always dissect the undersurface first because it's a very fixed landmark. You see the peripheral arcade and you know where you are. And following that, I dissect the superior surface. Here you can see that I've cut open the septum, which keeps the preaponeurotic fat pad invested. And those are the 2 layers of the septum. Septum again looks white like the levator and sometimes can be confusing, and therefore dissecting the underbelly always helps when you approach it undersurface first and then the superior surface. Once you have the desired height of the aponeurosis dissected, you generally tend to take 3 sutures. I prefer taking proline sutures. These are 6-proline sutures. And I always take the medial and the lateral suture as well, even if the central suture has given me the height and contour that I desire, because this avoids a post-operative droop. A post-operative medial droop is very common in patients with ptosis. So once the central suture has given me the height and contour that I'm looking for, the medial and lateral ones are just supporting sutures that go almost at the same height on the levator. Now here's where you can play around a little bit in terms of where the height of the medial and lateral suture goes and where the tarsal insertion goes to kind of correct the contour and height if you've not got it with your central suture. I generally tend to resect the residual stump of the levator muscle. I was not pretty happy with the contour, and that's why I've taken 1 additional suture here. This is the playing around that I was talking about. And then you form the lid crease formation suture. I tend to take the inferior lip of the incision and anchor it to the cut edge of the levator, and then close the skin with interrupted sutures. And this is the patient pre-operative and post-operative at about 6 weeks. She has a good lid height and contour which matches the contralateral side. The second surgery that we'll discuss is frontalis muscle flap, and this this is a surgery which I think more than me wanting to do it these days, my patients come to me and ask me that, do you perform the surgery? That's the newest surgery for ptosis, and it's gained quite a lot of popularity these days. So the initial steps are very similar to a levator resection, where you take your lid crease incision. Generally these days, this is one of my earlier recordings, I these days also harvest the levator and take sutures through both levator and Mueller's, but this is probably one of the very first surgeries. So what I've done here is gone right on the superior orbital rim, and I am isolating the frontalis muscle from above the superior orbital rim. That's the flap of the frontalis muscle that I've created, and you anchor it to the tarsus, very similar to what you would do with a levator resection. Now when you're taking both the frontalis and the LPS, the lid has a better vector and it moves posteriorly rather than moving only superiorly if you take just frontalis muscle flap. These are bulky flaps, and sometimes you may need to debulk a little bit of the frontalis, and then you go ahead and form your lid crease very similar to what you would do for a levator resection. I generally tend to overcorrect a little bit when I'm doing a frontalis muscle flap. I also see significant lag of thalamus in the initial postoperative period, and therefore I always take a temporary suture tarsorrhaphy lateral paramedian to avoid exposure keratopathy. I do it with a Vicryl, which tends to fall off in a couple of weeks itself. And this is how this patient responded. This is, I think, about a week post-op, and this is about 6 weeks to 3 months. I do not agree with the fact that frontalis muscle flap produces less lag of thalamus than levator resection. I've seen my patients have just as much lag of thalamus as a levator resection would give me, but nonetheless, this is, like I mentioned, this is more of a surgery that patients demand for than what you probably might want to perform. The next one here is Mueller's muscle conjunctival resection. This is a posterior approach to correction where you are shortening the Mueller's muscle. And this is a patient with an anophthalmic ptosis, and quite surprisingly I figured that in the series of patients that we studied, Mueller's muscle performs better than levator resection in anophthalmic ptosis. Levator resection always gives significant overcorrection versus Mueller's muscle, which kind of gives you the appropriate correction and does not worsen lag of thalamus in these patients. So the procedure is fairly simple. You see the Putterman's clamp being used over here, into which you clamp your Mueller's muscle and conjunctiva. You decide the amount that you want to resect, and you clamp that much tissue, and you run a suture in both directions. I typically like to use Proline. In our part of the world, we don't have catgut, but catgut is an excellent option for using in Mueller's muscle conjunctival resection as well. And then I like to exteriorize the suture and tie the suture on the skin surface, so that at 1 week or 10 days post-operative visit, I can just remove the suture. Once you've tied the suture, you resect off the amount of tissue that you had decided that you will resect, and you can see that she has almost immediate correction following Mueller's muscle conjunctival resection. This is another cited patient in whom we've performed this surgery, mild ptosis, just to symmetrize the tarsal platform show pre and post-operative. And here is yet another patient with a tarsal platform show and mild ptosis, where we've again done a Mueller's muscle conjunctival resection and had good outcomes. The last bit is the frontalis sling. Now I tend to prefer using an open sling technique, whether I'm using silicone or PTFE or fascia lata. I tend to open up the eyelid crease and fix the sling material on top of the tarsus. And I do this because epitarsal migration is one of the common causes of failure, especially when you're using silicone quite a bit. I use a pentagon technique that you're seeing over here. The initial steps of dissection again are very similar to levator resection, where you expose the superior border of the tarsus, because that's where you're going to anchor your sling. An 18 gauge needle is a perfect needle to use with the bodkin of the silicone rod. It fits into it perfectly and helps you to navigate the needle out much better. And then you pass your entire sling in the pentagon fashion like I'm showing you here. This is the epitarsal bite that you take, and then on the contralateral side, going back towards the brow, and finally coming out from the brow incision onto the central incision on the forehead. You could again play around with these incisions and have them less prominent by changing the position. You could bring the central forehead incision a little lower as well. That was the epitarsal fixation that I do with Proline. I check the contour. If I'm getting a good contour, I go ahead and form the lid crease. So the second advantage I get with this technique is I'm able to give a good tarsal platform and form the lid crease, which otherwise doesn't happen quite nicely in patients who are having frontalis suspension. And then you just tuck the two ends of the silicone into a pocket that you've created in the forehead and close the incision. I use Vicryl typically to close the brow incision, And here's a child who's had frontalis suspension. He had amblyopia on the left side and needed surgery to correct the visual axis. And even though it's just, you know that this child is going to need a revision later on, I would still prefer to perform an open sling so that I can delay the correction as much as possible. And finally perform just another surgery when the child is about 8 or 10 years of age to give them good correction of ptosis. In summary, I've spoken to you about the 4 techniques of ptosis repair that are widely used. Levator resection, probably the commonest performed procedure, helps you symmetrize the tarsal platform and also helps you correct the eyelash contour. You can correct the lash ptosis as well. Mueller's muscle conjunctival resection works beautifully in mild ptosis, especially in anophthalmic ptosis. Frontalis suspension, my choice is to open it up and do an open sling technique and do an epitarsal fixation. And for frontalis muscle flap, like I mentioned, at this point of time, I do it purely out of patient pressure and peer pressure. I do see a lot of lag ophthalmos, and I'm not very sure if this is the surgery that's going to change how we manage ptosis in future. Thank you so much.